Good evening, everybody. We're just giving it another 2 minutes or 3 more minutes for people to join in and settle. So we will again be back. The speaker is ready with his presentation. We'll just give it 3 minutes for people to join in. Thank you. Good evening, everybody. I think we waited. So it's already 4 minutes past 7:30 now. I think we should begin. This is the last but one series in current psychopharmacology that we're talking about. Today we have Dr. Mohan Kumar, who's going to elaborate and talk about the medication, the dose adjustment that we need to do when we're dealing with special population and different circumstances. We do a lot of corrections for the gender, age, sex, and sometimes appetite-related issues also. So in this current day series, we are going to look at this sort of fine-tuning of doses in terms of selection of the doses, selection of medications, and also look at special circumstances which will help us determine the right medication for the person in crisis. Dr. Mohan has done enough work, so one more talk on the series to go, and I think he would be a happy man to retire at the end of the series after doing 9 long sessions in a very innovative way. Team from Teleauga is really thankful for all the effort that he's been putting in, and it goes on for the next 2 more sessions. Over to Dr. Mohan Kumar. You can take the session to the penultimate event today.
Thanks.
Thank you.
Thanks, Mahesh. Thank you. So I guess we have been talking about dosing and adjustments through and through in session, depending on various molecules we've been talking about. So I thought I wanted to highlight in this session couple of topics which we generally don't discuss much, but actually are quite a challenge in our routine clinical practice. So I will be revolving 3 main conditions out here. One is attention deficit hyperactivity disorder, the challenges, the understanding what we can have when we prescribe the molecule and those things, dementia to some extent, and of course, I'll briefly touch upon obesity and the kind of molecules which are there with which we can try to work with people who are obese and how to kind of help them in pharmacological strategies. So I'll try to kind of keep it very crisp and clear so that we understand at least some basics of all of the topics we want to talk about. I'm sure as a clinician, you might be having this day in and day out question which is coming in, where a young person who's most probably IT sector employee or engineering or a medical student who comes and says, "Doc, do you think I have ADHD or ADD?" Or they come and ask you whether I have adult ADHD. And this kind of questioning population is only increasing over a period of time to our knowledge. So I remember very well a few years back, we were not even talking about adult ADHD. Today, we do talk about adult ADHD in a significant way. Almost many conferences have at least one topic on adult ADHD and those. Why are we supposed to talk about it, and what is the importance, and some basic science of understanding it is what we look at. Now, if you look at ADHD, which is attention deficit hyperactivity disorder, there are 3 main things we specifically look for, right? One is we look for inattention. Next one is impulsivity. And the third one is hyperactivity. We look for 3 important features: inattention, impulsivity, and hyperactivity. These are 3 core features we look for in the individual. Whether it's a child or an adult, we look for these core features. In each individual, it could be different intensities and severities, but the core problems will be in attention, impulsivity, and hyperactivity. Now, when you're talking about inattention, there are 2 specific attentions you're looking at. One is selective attention. For example, if there are 100 things out happening in your room, are you able to focus on the laptop screen or the mobile screen? The ability to focus on it is your selective attention, right? So that selective attention component is extremely useful in a classroom, because if there are 40 kids sitting around, there are 2 kids in front of the person talking, the kid has to focus on mathematics class rather than actually kind of focusing on the 2 kids who are talking among themselves. So they should be able to selectively focus and kind of concentrate. That's a component of attention we are looking at. Sustained attention basically means our ability to kind of concentrate over a period of time. We want the child to be with the teacher for about 45 minutes to an hour till the class gets over, right? So that's when they get the concept correctly. So these components can sometimes go haywire. And if you look at neuropsych, the areas of the brain which play a role in selective attention and sustained attention are the dorsal anterior cingulate cortex for the selective attention, whereas the DLPFC plays a sustained attention role. DLPFC plays a role in executive functioning and many other things, which we'll talk about again. Now, when you're talking about impulsivity, you're talking about the orbitofrontal cortex, as well as when you're talking about the hyperactivity, you're basically talking about the prefrontal motor cortex. Now, why is it a good idea for us to remember these kind of areas in the brain? I'm sure a lot of times we know of people who have been doing well, unfortunately have a road traffic accident and a head injury. Post that injury, they survived. The family members are happy that the individual survived. But what we do not notice is they would have survived, but the head injury could have had serious impact on their cognitions and those. We do see a lot of personality change which can happen. We do see diffuse brain injuries, and which can actually lead to kind of impulsive behaviors, attention issues, hyperactivity issues, which can come in at a later age. Now, these are quite challenging age groups to deal with sometimes. So it's important for us to understand the areas of the brain which play a role in these symptoms, so that if these areas of the brain, for whatever be the reason, whether it is tissue damage, whether it is a tumor growing there, whether it is a traumatic injury, it might affect the outcomes of the individual's overall functioning. Now, what basically happens is with ADHD adults or children, we typically see that there is inefficient information processing. The DLPFC, which is the executive functioning center, kind of inefficiently processes information. So basically what can happen is the child can get distracted much easier or cannot concentrate for a very long time, which can lead to poor academics and other problems. Now, why is it very important for clinicians to look for these symptoms? Because you need to understand, for you to say whether the person is having ADHD as an individual condition which is causing these symptoms, or is it part of some other comorbid condition or a primary condition which is causing inattention, impulsivity, or hyperactivity, like depression, anxiety, schizophrenia, substance use disorders, and many other conditions can definitely have symptoms similar to ADHD at varied levels of severity. Why is it important for us to know? Is because traditionally we know ADHD is a developmental condition, and as the child grows older, we say they will grow out of ADHD. Very common in a lot of pediatricians is the parents would go and ask them, Doc, this child is not able to sit at one place, is very hyperactive. So do you think we should go and meet a psychiatrist or a psychologist? A lot of pediatricians in good faith will tell, don't worry, as he becomes older, things will be okay. Yes, some of the kids can grow out of the ADHD, but in reality, if the person is actually having a full-fledged ADHD, the chance of just growing out becomes much, much lesser. So you need to understand, the earlier you intervene, the earlier you help these kids as they're growing up, would have long-term impact in terms of outcomes. One thing is very clear is as they become older, something which comes down significantly is hyperactivity. Now, ADHD in kids, hyperactivity is a very common and important feature, whereas ADHD in adults, we typically don't look at hyperactivity as an important feature. That's important difference between adult and child ADHD, right? Next important thing is, most of the times the kids are much more impulsive, and as they grow older, the impulsivity might come down to some extent. Not as much as hyperactivity, but impulsivity also can come down. What traditionally does not come down, or the deficits continues to remain, is the inattention. The inattention typically does remain over a period of time. We also know, even if you look at gender, right, the male and the female ADHD kids who are there, inattention is very, very common in females. And most of the times these kids are thought to be lazy. These kids are thought to be not motivated to attend classes. These kids are thought to be kind of wantedly doing it and those. Now, when a kid is hyperactive and impulsive, breaking things, running and hitting and those, they are brought for intervention much earlier because they are creating trouble. But whereas these inattention people are very silent and self-absorbed. So since they don't trouble anyone else, they don't reach out to professional help much earlier. So we lose on a lot of these kids who are suffering from this inattention. So whenever you're evaluating the kids, it's a good idea for you to ask yourself, are you missing inattention in the kid? So deliberately trying to see whether the child is able to sustain attention, selectively be attentive enough, are important questions clinically for us to look at, for us to kind of evaluate clinical ADHD symptoms. It is important for us to understand. We used to say people will grow out of ADHD, but over years, more and more data and more and more emphasis is now very much there about adult ADHD. At least to my knowledge, when I finished psychiatry about more than a decade back, the amount of emphasis which was given for adult ADHD was way lesser compared to what is given now for adult ADHD. For a simple reason is because today we know if you don't help these individuals with adult ADHD symptoms, they actually go on needing more mental health interventions and support. So it is important for us to kind of look at adult ADHD as a component and treat, first of all, diagnose and then treat these individuals specifically. The challenge we have as clinicians is very few people might come to us with adult ADHD kind of a symptom or asking whether they have adult ADHD. A lot of times, as a clinician, we might see they coming to us with various comorbid conditions. Comorbid conditions like substance use disorders, mood disorders, and anxiety disorders are very, very common comorbid conditions where they come in. Now, this is extremely important for us to look at because if you are giving medication at an adequate dosage for an adequate trial, but you're not seeing much improvement in any of these common conditions like mood disorders, anxiety disorders, or even substance use disorders, it is good idea for us to look for comorbid conditions. One of the comorbid conditions which should seriously look for is adult ADHD. The problem here about adult ADHD is adult ADHD can become a breeding ground for a lot of these comorbid conditions. And unfortunately, a lot of these comorbid conditions can have same or similar symptoms like adult ADHD. So it's a good clinician's job to tease out and see whether they need specific medications for their adult ADHD symptoms. I can't tell you the number of times we have been able to help the individuals when we have found clear-cut ADHD symptoms in them. When we give them proper ADHD medications, they seem to settle down with their anxieties significantly. They seem to settle down with their substance use problem. In the earlier lecture in the series, we spoke about substance use disorder. You need to understand, if you see today, a lot of younger population are quite aware of what is actually happening. They read up, they search on the net. If you see, a lot of them are actually using alcohol and weed especially to treat their hyperactivity and impulsivity and those things. So you need to understand that a lot of times they self-medicate with these substances because of these comorbid conditions and other things, and they might have an underlying ADHD which they might have not been identified yet. So it is important for us to look for the individual, whether they have ADHD symptoms, whether it is adult ADHD, and whether it is a comorbid condition, which is very important, and trying to know which is the core problem which you should address here. Now, with this kind of a basic clinical understanding, let's go back to a little bit of neuroscience and neuropharmacology for us to understand. Now, I did mention about prefrontal cortex, right? In the prefrontal cortex, the two main chemicals which play a role in ADHD is dopamine and the norepinephrine. Now, dopamine and norepinephrine are two chemicals which play a role in the prefrontal cortex in ADHD symptoms. Basically, there is a tonic firing which happens. When I spoke to you about anxiety disorders, in that video, if you look at, I would have spoken about phasic firing and those. Now, phasic firing, I also spoke to you in substance use disorder. Here, they're talking about a tonic firing. A tonic firing is a low threshold firing, which is constantly happening. This low threshold firing in the dopamine and the norepinephrine neurons is very much required for you to have a decent amount of attention and concentration. If this goes haywire, then you end up developing ADHD as a condition. So dopamine basically is linked specifically with D1, D2, D3 receptors in the prefrontal cortex. The norepinephrine is mainly linked with the alpha 2A receptors. Of course, it can be linked with the alpha 1 and the beta 1 and other receptors also. For us in ADHD, you need to understand we are specifically looking at the dopamine, which is linked with D1 receptors, as well as norepinephrine, which is linked with alpha 2A receptors. I'll try to make it more easier for us to understand in a few minutes' time. Now, what you need to know here is this dopamine plays a role in reduction of noise. The dopamine plays a role in reduction of noise, whereas information is enhanced by norepinephrine. Information is enhanced by norepinephrine. So do you remember in substance use disorders, I did mention to you about the phasic firing which happens. This phasic firing which happens could be one of the explanations for why somebody gets wired towards a substance or gets attracted towards a substance. Or in anxiety disorders, we spoke about phasic firing because it can lead to a spurt of anxiety. So that is what typically happens in phasic firing. But what are we talking about here? We're talking about the tonic firing. So this dopamine and norepinephrine is trying to kind of maintain a balance. The two main receptors for ADHD we should be looking at is the alpha 2A, which is norepinephrine linked, and the D1 receptors, which is dopamine linked. So these two receptors activity are important for us to explain ADHD. Now, alpha 2A is linked with the G protein, which is inhibitory in nature, whereas dopamine 1, D1 is linked with the G protein, which is stimulatory in nature. So one is inhibitory, one is stimulatory in nature. So what do they inhibit and what do they stimulate? They inhibit and stimulate something called as HCN. What does this HCN stand for? It is called as hyperpolarization activated cyclic nucleotide gated cation channel. To make it easy, I'll kind of put it across in a simple way. Let's imagine there is an information which is coming through. As the information comes on, there is this HCN channel. What is this HCN channel? HCN channel is nothing but hyperpolarization activated cyclic nucleotide gated cation channel. Cyclic nucleotide gated cation channel, HCN channel. Now this HCN channel can be open or it can be closed. So this HCN channel can be open or it can get closed. So it can keep opening and closing. So this HCN channel is something which is very important for us to understand ADHD. What happens to this HCN channel? When it is opening and closing, different things can happen. For example, when it is open, the information which is coming, if you see, leaks out of the open channels. Out of the open HCN channels, the information leaks out. When the information leaks out, what information goes is very little. So basically, there is not much of information which goes beyond that leaky HCN channels. But what happens when it is closed? When HCN is closed, a lot more information can go. So if you see, what is happening here is the HCN channel by opening and closing. When it opens, it leaks out. So the information goes is very little. When it kind of closes, the information goes is significantly high. So thereby, the tuning of information is happening through this HCN channel, which is taken care by the D1 receptors and the alpha 2A receptors. They too take care the HCN channel opening and closing. So what do they do is by opening and closing, they tune the information which is passed through, and it does two important things. One is signal amplification and another one is noise reduction. Signal amplification is done and noise reduction is done. Both are important, and one working too much and the other one not working could lead to problem. So what you need to understand is Too much of norepinephrine dopamine also is a problem. Too less of norepinephrine dopamine is also a problem. You need a balanced system out there, and that is what will maintain a normal period. In ADHD kids, we see it is hypofunctioning of the norepinephrine and the dopamine system. So signal amplification and noise reduction becomes an issue. If you see ADHD as an illness, you know when too much information comes also the kids find it difficult, or too little information comes also they find it difficult. They get very easily bored because they kind of are very distractible and those things. So all of these are explained by the processing of the information through this HCN channel, which is linked to two important receptors. Which are the two receptors? The alpha 2A receptors, which is linked with the norepinephrine, and the D1 receptors, which is linked with the dopamine. So with this understanding, try to kind of highlight you, there's a delicate balance between the signal and noise. The signal component is taken care by the norepinephrine. The noise component is taken care by the dopamine. Whenever this balance becomes too low or too high, you have problem. When it becomes too low, it leads to unguided attention. Unguided attention means you're not able to focus at one thing, so you're very distracted. Or when the noise is too high, what actually happens is misdirected attention. You want the kid to concentrate on this, but the kid is concentrating on something else. Have you seen as a kid, a lot of times what we do, we are sitting and reading the book, but we know which advertisement is coming on the TV channel. Our attention is there, but our attention is misdirected into something else. So that is exactly what happens with children with ADHD. So they might, first of all, not be able to focus, or if they focus, they're focusing on the wrong thing rather than the priority thing which they are supposed to be focusing. This delicate balance is what we are trying to correct by giving various molecules and medication. Now, as I already mentioned to you, in another simple way to put across, ADHD is basically decrease in the norepinephrine and decrease in dopamine. Thereby, it can decrease the signal and increase the noise. The signal which comes can decrease and the noise can increase. When noise increases, when the background sound increases, automatically your quality of executive functioning will come down, your quality of cognitive functioning will come down, and that is exactly what you see in ADHD people, right? Now, I'm talking to you that ADHD happens because of lower norepinephrine and lower dopamine. What do you think happens when people are stressed? When people are stressed, the opposite happens, right? So what is the opposite thing? Let's imagine people are in chronic stress. When people are in chronic stress, there is an increase. Increase in what? Increase in norepinephrine and dopamine levels. There is an increase in the norepinephrine levels and the dopamine levels. This increase in dopamine and norepinephrine levels goes to such an extent that they go and flood the synapses and the receptors. By this flooding, what happens is after a point of time, because of excessive release of norepinephrine and dopamine, there reaches a stage of exhaustion. And once this exhaustion sets in, what happens? It is almost like the previous state, right? So all your dopamine and norepinephrine are released and it's constantly released. When it's chronic stress, everything gets exhausted. So there is a relative decrease in the dopamine and norepinephrine. So the treatment is again going to be stimulants. So when norepinephrine and dopamine is lesser in patients with ADHD, you give stimulants. In chronic stress, logic says chronic stress means increase in dopamine, increase in norepinephrine. Please understand, it does increase. If it is chronic stress, over a period of time, there is an exhaustion which happens. And because of this exhaustion, the dopamine, norepinephrine are not working efficiently. So you again need to consider stimulants. So the simple treatment for ADHD is using stimulants, Now, when I was initially reading psychiatry, I used to think the child with ADHD is already kind of stimulated accordingly, very hyperactive, very restless, agitated, wanting to do many things. And how can you give a stimulant to a child who's already stimulated was the logic which I had applied when I was kind of learning my psychiatry. But it is later on when I realized that they are very distracted, or their executive functioning is not channelized properly. As I kind of put up in the picture, that HCN channel is there, there's a lot of leaking which is happening, or there's unnecessary information which is coming, which is leading to dysfunctionality. And when you give the stimulants, it helps them to focus on what you really want them to focus, thereby they actually get better in their symptoms. One of the important stimulants we need to understand is methylphenidate. Now, methylphenidate is inhibiting the transporters. What transporters does methylphenidate inhibit? It inhibits the norepinephrine transporter. It also inhibits the dopamine transporter. So we have discussed earlier also in previous lectures series that norepinephrine transporter and dopamine transporter inhibition will lead to increase in norepinephrine and dopamine levels, right? So that's something which we should know, which happens with methylphenidate. So that is the reason why methylphenidate is extensively used and useful treatment in patients with ADHD, attention deficit hyperactivity disorder. Now, I have a question here. Can methylphenidate enter the presynaptic neuron? Can methylphenidate enter the presynaptic neuron is the question. Methylphenidate is a competitive inhibitor. Methylphenidate does inhibit the transporter. How does it inhibit? Does it do a competitive inhibition or not? Now, one of the important stimulants which we use in India is methylphenidate. Now, that's what we do in India. But what you need to know here is, if you talk about methylphenidate, right? Methylphenidate actually does not enter into the presynaptic neuron, even if you increase the dosage. Methylphenidate is not a competitive inhibitor, is what you need to understand. So, which drug is actually entering the synapse and which drug is the competitive inhibitor? This is where you need to understand we are talking about amphetamines. Amphetamines. Now, I'm sure if you're practicing in any of the cities, you will have some of the kids who have, or young adults who have from India gone to study in US and they have been diagnosed with ADHD or adult ADHD, or these are families who have settled down in US and have come back to India. Now, you'll see a lot of these kids coming and saying, I've been taking Adderall. Now, this Adderall is amphetamines, and in India, to my knowledge, it is obviously not available for treatment purposes. So what you need to understand is a lot of these kids who are actually taking amphetamine, Adderall, is a drug which can enter into the presynaptic neuron, and it is a competitive inhibitor. Now, one of the reasons I'm talking about this is because amphetamines, the moment I talk about it, you might wonder, oh my God, this is what we talk in substance use also, right? The amphetamines are one kind of stimulant drugs which people abuse. Now, you need to understand, typically the dosage of amphetamine, which is clinically used, is much lesser. But when you use much higher dosages for abuse, what happens is that higher dosage of amphetamine can not just inhibit the transporter, like methylphenidate, it will get inside the nerve cell. It can even reach into the vesicles and disturb the vesicles and throw out all the dopamine which is sitting out in the vesicle. So amphetamine has a tendency to get absorbed into the vesicle and actually throw out all the neurotransmitter which is sitting in the vesicle, which thereby leads to a gush of dopamine which can happen, and that can lead to the high and euphoria and hallucinogenic effect and all those kind of stuff which can happen with amphetamine. So why am I stressing this point is because a lot of times, if you even prescribe, of course we don't prescribe amphetamine as such, but imagine tomorrow we have licensed products of amphetamines. If you start prescribing, I'm not going to be surprised if the patient's parents or the patient himself reads up and comes and asks us question, Doc, is it not a drug of abuse? Why are you giving this to me? You need to understand, typically a drug of abuse, amphetamine, is much higher dosage. And at that high dosages, you need to also understand they inhibit the vesicle. What is VMAT2? You would have seen, I've discussed this in earlier in the same series, right? VMAT2 is vesicular monoamine transporter 2. Vesicular monoamine transporter. These are transporters which are sitting in the vesicles. Now, I told methylphenidate inhibits the norepinephrine and the dopamine transporter. If you see amphetamine, it does do that, but when its concentration is high, it can get into the nerve cell also. It then can enter into the presynaptic neuron. It can reach even the vesicles. It can even inhibit the vesicular monoamine transporters. Thereby, inhibiting that, it increases the levels of dopamine to very, very, very large extent. So amphetamine, when it is used in abuse potentials in much larger dosages, can cause these effects and thereby leading to release a lot of dopamine. So that is the reason why generally our prescriptions of amphetamine is not going to be addictive, but you need to be aware that amphetamine can also be a substance of abuse depending on the dosage which people use and the vulnerability they have. Now, other than these, one of the important stimulants we use in India very commonly is atomoxetine, and atomoxetine is specifically very, very useful in people who have history of abuse potential, right? Who have history of abuse potential. Now, atomoxetine is a norepinephrine transporter inhibitor. More than dopamine, it's a norepinephrine transporter inhibitor. So it basically increases the norepinephrine levels. Atomoxetine was kind of tried to see whether it has antidepressant effect, but its antidepressant effect was never efficacious to be clinically relevant. But atomoxetine has still remained as one of the drugs which is very useful in people with ADHD. And since it has less chances of abuse potential, it is a drug of choice in adult ADHD where they have very significant family history of substance use, or if you're worried about an abuse potential in the individual, you can think of atomoxetine as a choice. It's quite well tolerated in most of them, so it's considered as one of the treatments in people with history of substance use potential chances. Talking about bupropion, we have spoken about bupropion in earlier few discussions about antidepressants, even anxiety medications and those. Even last lecture, we spoke about tobacco cessation with bupropion. It's important for us to know bupropion inhibits both the norepinephrine transporters and the dopamine transporters. Thereby, it increases the norepinephrine levels and the dopamine levels. As I already told you, ADHD is because of decrease in norepinephrine and decrease in dopamine, whereas bupropion will try to enhance both of these things to some extent. So that is the advantage of trying out bupropion. One of the common places where you can consider bupropion is you will have a lot of these patients who come to you where you think they might be having depression symptoms, and they also have a lot of cognitive functioning problems, memory issues, they're not taking initiatives and those things. In them, trying bupropion could be very effective because it is known to improve some amount of working memory and cognitive abilities and those. So it's a very good idea for us to consider bupropion. So basically looking at the symptom potential, whether you need to give a stimulant, whether there is a risk of abuse where you want to think of atomoxetine, or off-label drugs like bupropion, and those things could be considered. One of the other important off-label drugs, which is very commonly also used sometimes in India, especially in younger population, is who actually is a US citizen, came and met me and said, I need a prescription because the kid is having ADHD and for the next couple of years will be here in India. One of the medications the child was taking methylphenidate, which was easy for them to procure in the market. The other medication was guanfacine. Now, guanfacine is an alpha-2A agonist, and it is a selective alpha-2A agonist. Now, guanfacine, unfortunately, is not widely available in our country, so it makes it difficult for people to take it, but it seems to have its own promising effect in terms of alpha-2A agonism. So these are some various interesting choices which you can consider while you are trying to handle these people with ADHD symptoms. Now, ADHD is not just about dealing with medications. You can teach a lot of behavioral strategies and the other aspects. I haven't gone into that because that's a different topic altogether. So let's move to a different age group now. We'll come to the other side, the elderly population, or the people on the geriatric population side. Constantly as a clinician, we are going to have this common challenge. they'll come and say, I'm forgetting, or I'm not able to remember things. You're asking yourself, is it just normal aging? Is it some minimal cognitive deficits, MCD, MCI, or is it dementia? So you want to know whether it's normal aging, is it minimal cognitive deficits, or is it dementia? And why should you be looking for minimal cognitive deficits? The reason is because we know a lot of people with minimal cognitive deficits over a period of time can go on to develop dementia. There are various propositions to say what percentage of them can go to minimal cognitive deficits. It is important for us to know that minimal cognitive deficits uh, alone is not enough. You need to look for other risk factors which they have, which can tell what is the risk of getting into dementia processes. Now, we also know a lot of micronutrients are available today. A lot of companies speak about cognitive enhancing syrups and molecules and those. We don't know how efficient it could be, and it is very difficult to study the efficiency of these things in these populations. So wherever possible, and especially because these drugs are quite costly, if they can afford it, and if they don't have side effects, especially if you think there could be micronutrient deficiencies, you can always consider adding micronutrient supplementation, because we know diet and those can influence worsening of progression of neurodegenerative conditions. Now, it is also important for us to know about, I'm just going to specifically talk only about Alzheimer's disease, but some of these principles are also linked with the other conditions which happen, right? So when you're talking about Alzheimer's disease, there are two important changes which happen. One is the problems in the tau proteins. Another one is a problem in the beta amyloids, tau proteins and the beta amyloids. So tau proteins gets accumulated in the intracellular areas, and these are called as neurofibrillary tangles, whereas beta amyloids get accumulated in the extracellular area, and these are called as amyloid plaques. Amyloid plaques. When you're talking about Alzheimer's disease, you need to understand APP. What is this APP? APP is nothing but amyloid precursor protein. Amyloid precursor protein. This amyloid precursor protein is nothing but a transmembrane protein. It's a transmembrane protein with a C side, which is inside the cell, and the nitrogen side is in the outside of the cell. Okay, so N side is outside the cell, whereas the C side is inside the cell. This amyloid precursor protein gives rise to A beta peptides. A beta peptides, some of it could be non-toxic and some of it could be toxic. So the A beta peptides which are produced from the amyloid precursor protein, some of it could be non-toxic and some of it could be toxic. The toxic ones are the ones which gets to lead to Alzheimer's disease. When these toxic beta peptides kind of get accumulated, especially in the extracellular area, it leads to the death of the nearby nerve cells and leads to inflammatory processes, and thereby lead to Alzheimer's disease. Now, Alzheimer's disease vulnerability depends on how much of formation of A beta peptides can happen and how much of removal of this can happen. If the formation is very fast, the risk increases. If the removal is very slow, the risk increases. So there are a lot of genetic factors also which can play a role in Alzheimer's. I'll try to touch upon it in a simple way in a few slides. So here is this amyloid precursor protein. Now, when this amyloid precursor protein is sitting out there, the alpha secretase enzyme breaks the amyloid precursor protein into an 83 amino acid peptide and a soluble alpha APP, amyloid precursor protein. Okay, so there is a soluble component which is the alpha APP as well as the 83 amino acid peptide. This 83 amino acid peptide is further worked upon by the gamma secretase enzyme, and that divides it or splices it into small pieces of P3 and P7 peptides. P3 and P7 peptides. This is what most of the times happens when alpha secretase works. But when a hero is there, we always need a villain, right? So who's the villain out there? The beta secretase. So what does the beta secretase do? The beta secretase, when it comes and works, it works on the amyloid precursor protein. It breaks it into a 91 amino acid peptide and a soluble beta amyloid precursor protein, a soluble beta amyloid precursor protein, and a 91 amino acid peptide. By breaking it down into a 91 amino acid peptide, further action of gamma secretase leads to what? The further action of gamma secretase leads to production of three different common peptides, the A beta 40, A beta 42, and A beta 43. A beta 40, 42, and 43. Out of which this 43 is quite toxic and amyloidogenic. The 43 accumulation leads to further conglomeration and degeneration and amyloid plaque formation, especially the A beta 43, which gets accumulated significantly. Now, this is one side happening with the amyloid protein production. So, what is the other one which is linked with the Alzheimer's disease? The tau protein. So, what happens with the tau proteins? The tau proteins, which are cytoskeleton proteins or the neurofibrillary tangle in the intracellular areas, these are cytoskeleton proteins, the tau proteins. These get phosphorylated. So when they get phosphorylated, they get entangled, the cytoskeletons get entangled and lead to debris formation. That is what is called as neurofibrillary tangles, which happen, neurofibrillary tangles. So in Alzheimer's disease, if you see, there is the extracellular component, there is the intracellular component. In the extracellular area, you have the beta amyloid plaques which get formed. In the intracellular area, the phosphorylated tau proteins leads to the formation of the neurofibrillary tangles. Now, these degeneration bodies ultimately lead to increase in inflammation, increase in cell injury. They also ensure that they affect the neurotransmission significantly. If you remember, in a couple of slides back, I said faster formation of these plaques or tangles could lead to increased risk of Alzheimer's disease. So there is a protein called as apolipoprotein. This apolipoprotein has three important alleles. One is E2, E3, E4. Now, this apolipoprotein basically can play a role in removal of this amyloid plaques. Can play a role in removal of this amyloid proteins. So this apolipoprotein E4 can have three alleles, that is E2, E3, and E4. E2 is known to decrease the risk of Alzheimer's disease, whereas E4 is known to increase the risk of Alzheimer's disease. E4 is known to increase the risk of Alzheimer's disease. That's an important point for us to remember. The reason is because when E4 allele is there, the apolipoprotein is not efficient enough to remove. So there is more accumulation of amyloids, which leads to neurodegeneration and further progression. Now, there are various genetic contributions which can happen. There are some important genes which play a role. I'll just tell you the name, and it's a good idea for us to remember how these get connected. The basic idea here is for all of us to kind of have an idea of some of the terms which comes in these conditions, so that these are all molecules which are being targeted in further research, and people are trying to develop molecules to work on these proteins and those. So the chromosome 21 is linked with the amyloid precursor protein. I told you just now, right? Apolipoprotein E4, that is linked with the chromosome 19. Tauopathy is linked with chromosome 17. If I told you, right, phosphorylated tau protein, that is linked with the chromosome 17. If you talk about chromosome 14 and 1, chromosome 14 is linked with the presenilin 1, whereas chromosome 1 is linked with the presenilin 2. Now, presenilin 1 is an important gene which is linked with familial autosomal dominant Alzheimer's disease. Familial autosomal dominant Alzheimer's disease is very commonly linked with the presenilin 1 mutations. Now, chromosome 6 is linked with the TREM2. What is TREM2? Triggering receptor expressed on myeloid cells. Triggering receptor expressed on myeloid cells. TREM2 is linked with the chromosome 6. So these are some of the important chromosomes which is linked with the genetics of Alzheimer's disease. So basically, you would understand that Alzheimer's disease has multiple factors play a role. So that is one of the reasons you sometimes see it runs in families, and some risk factors are carried in families. Now, to kind of look at how do you manage these patients with any kind of dementia, especially Alzheimer's dementia, it's important for us to understand is we're looking at two things. One is we want to increase the levels of acetylcholine. We know acetylcholine plays a role in cognitions, especially memory. So we want to increase this acetylcholine, and we want it to remain in the synapse for a much longer duration. And another strategy of working with dementia is by creating NMDA antagonism. NMDA antagonism. When you're talking about acetylcholine, first, you need to understand one important area you should remember is the basal forebrain area, where you have the nucleus basalis of Mayenut. Nucleus basalis of Mayenut is there in the basal forebrain area, which is one of the important sources of acetylcholine, which plays a role in dementia processes. Because there is less acetylcholine, dementia is seen. Now, CAT is important for us to remember when you're talking about acetylcholine, because the choline acetyl transferase, CAT, choline acetyl transferase, leads to the production of acetylcholine. From where does it produce acetylcholine? From the choline and the acetyl-CoA. From the acetyl-CoA and the choline, you get the acetylcholine. Now, this acetylcholine is further broken down by two major enzymes. One is the acetylcholine esterase. The other one is butyrylcholine esterase. So these are two important enzymes which break down the acetylcholine. That is the acetylcholine esterase and the butyrylcholine esterase. That's something which we should know. This acetylcholine can work on two important receptors. What are the two important receptors on which it can work on? The muscarinic receptors and the nicotinic receptors. There are 5 important types of muscarinic receptors: M1, M2, M3, M4, and M5, out of which M2 is specifically known to have a lot of presynaptic presence, and they act as autoreceptors when they are presynaptic present. Okay. Muscarinic receptors are basically G protein receptors. So basically it takes some time for it to work. It's a G protein receptor. Receptors, for that matter, is a ligand-gated ion channel receptor. Nicotinic receptors are ligand-gated ion channel receptors. There are two important nicotinic receptors and alpha-7 nicotinic receptors. Even in the last lecture, we touched upon the same receptors. So please remember the alpha-4 beta-2 is very much there in the nucleus accumbens area, plays a role in reward pathway, smoking, and those. So varenicline, you can look at that video for you to understand it better. Alpha-7 specifically is known to play a role in cognitions. It's known to play a role in feed-forward mechanism, thereby increasing further acetylcholine. And it is also known to increase the levels of dopamine and glutamate. Levels of dopamine and glutamate gets increased by the nicotinic action on alpha-7 receptors, which are there. So increase in acetylcholine, NMDA antagonism. Which are the drugs which increase acetylcholine? Some of the important ones are donepezil, rivastigmine, and galantamine. Whereas which is the drug which plays a role in NMDA antagonism? Memantine is the drug which plays a role in NMDA antagonism. So kind of before I just briefly highlight about some of these drugs, donepezil, if you look at, is a reversible acetylcholinesterase inhibitor, and it is a selective acetylcholinesterase inhibitor. So it selectively works on acetylcholinesterase inhibitor, whereas galantamine and rivastigmine to some extent can have some effect on the butyrylcholinesterase, whereas donepezil has least effect on butyrylcholinesterase. It mostly works on the acetylcholinesterase. That's one important point for us to remember. You know, donepezil is a drug which works in patients with mild to moderate dementia. Sometimes even in severe dementias, we can give donepezil and memantine. But what is important for us to remember is what is the commonest problem for which patients stop taking donepezil? If you see gastrointestinal symptoms, right? The acetylcholinesterase in the periphery, in the gastrointestinal tract, is the culprit. When it is inhibited, it leads to acetylcholine accumulation in the peripheral system, especially in the gastrointestinal tract, leading to nausea, diarrhea. Those are common reasons why people don't tolerate donepezil. Now, rivastigmine is also a drug which works on acetylcholinesterase inhibition. But please remember, rivastigmine is one of the drugs which is available in the form of patch, where you can apply the patch and it works through and through. So this is very useful when patients don't want to swallow medications and you have problems in oral intake and all. You can think of rivastigmine, but of course the patches come at a very huge cost. So you need to understand many of our Indian patients might not be able to afford these rivastigmine patches. Now, galantamine is the drug which is dual acting in nature. Galantamine is the drug which is dual acting in nature. So what is the dual action it does? Now, dual acting because it works on the acetylcholinesterase inhibition, but it also is a PAM. What is PAM? Positive allosteric modulator of nicotinic receptors. It is a positive allosteric modulator of nicotinic receptors. So that's the dual action which we are talking about here. Whereas donepezil and rivastigmine and all is typically working on acetylcholinesterase enzymes. Galantamine all works on the acetylcholinesterase enzyme, but also works on the positive allosteric modulator, means it works on the nicotinic receptors and allosterically positively modulates the nicotinic receptors. The two important receptors we spoke about is the alpha 7 and the alpha 4 beta 2, right? So that's something which you should know about galantamine. Now, what you need to also understand is memantine is a drug which plays in NMDA antagonism. NMDA antagonism. So what does memantine do? It works a little different way. Now, if you take the person's brain who's actually going through a neurodegenerative condition like Alzheimer's disease, there is a lot of leakage of glutamate which is happening. There is a lot of leakage of glutamate which is happening, and this leakage of glutamate over a period of time leads to excitotoxicity. What happens? The glutamate which is getting leaked into the neural circuits and in the synapses and in the intercellular areas leads to excitotoxicity, free radical injury, and those. So basically leading to excitotoxicity. Now this excitotoxicity is kind of prevented by an NMDA antagonist. And the NMDA antagonist we are talking about here is memantine, which we are talking about here. So what does this memantine end up doing here? The memantine actually kind of works on the NMDA antagonism. When you talk about NMDA receptor, I hope you remember we spoke in chapter on schizophrenia in detail about NMDA receptors and all. Go and look at that video for you to kind of refresh yourself about some of the components on NMDA antagonism and all. So what you need to understand about NMDA antagonism is this NMDA receptor requires three important steps. There should be some depolarization, there should be glutamate, there should be glycine. All these three things together should be in sync. That's when NMDA receptor works. When depolarization happens, when glutamate and glycine are sitting around, and most importantly, there is this magnesium which is sitting around and kind of closing this channel and blocking it. Magnesium, it kind of blocks and stops the functioning of the NMDA antagonism. Imagine the removal of magnesium. So then the NMDA receptor gets activated. So what does this memantine do? Memantine is almost like this magnesium, goes and sits and artificial. Memantine is called as an artificial magnesium ion. Memantine is called as an artificial magnesium ion. So it goes and sits in the NMDA receptor and it blocks that and does not allow the excitotoxicity to happen. It reduces the effect of the leak of glutamate on these neurons. That is why it is useful in people even with severe dementia status. Now, if you see the other conditions where the other drugs, the one which are acetylcholinesterase inhibitors, right? They go and work in the acetylcholine neurons and they inhibit the acetylcholinesterase enzyme, thereby increasing the acetylcholine, for which you need a lot of those neurons very much viable and alive. If the disease has progressed significantly, do you think so many neurons will be there? Not much. So that is where memantine, which is working on NMDA antagonism, is used in more of severe dementia conditions because it is not dependent on the acetylcholine neurons, it is dependent on reducing the excitotoxicity. Thereby, they think maybe the progression of dementia might be reduced by the usage of memantine, which is kind of considered as the artificial magnesium. Now, there are a lot of other potential treatments which are out available for Alzheimer's, and a lot of research happening. People have developed this COVID vaccine. I'm looking at some point of time, they might develop some vaccine, some immunization strategies, even for Alzheimer's. That day is not going to be far. But what are they trying to target here? We did see this picture earlier, right, when we were speaking about beta secretase and what it does and how does amyloid production happens. What you need to know is they are trying to develop potential treatment strategies by developing inhibitors of beta secretase. If you can inhibit beta secretase, automatically you inhibit a lot of next sequential steps, thereby reduce the chances of Alzheimer's. That is an idea which is being worked upon. They are trying to develop inhibition of gamma secretase. Now, gamma secretase inhibitors are another way of working upon to prevent Alzheimer's disease. They're also trying to work on amyloid lowering strategies. They are trying to use immunoglobulins. They are trying to use vaccines. They are trying to use drugs to lower amyloids out there. So in all these strategies, basically they are trying to kind of improve the functioning of the nerve cells and improve the degeneration and the accumulated excitotoxicity. All those things they want to kind of remove through and cleanse the brain, thereby help the brain to function at its best as long as possible. Now, as a clinician, it's a good idea for us to remember in a simple way that a diabetes brain, or a brain which is in poorly controlled diabetic state, is very, very, very vulnerable for Alzheimer's disease. So if at all somebody wants to not get Alzheimer's disease or wants to prevent it to the core, they need to maintain their sugar levels as normal as possible for the longest duration, because a lot of studies do say that diabetes could be a deciding factor about why a lot more Alzheimer's disease are getting reported over years. And India being the diabetic capital, you need to understand, unfortunately, there is an epidemic of number of cases of Alzheimer's, which is going to get reported as days go by, and we will have more of elderly population out there. So why I'm stressing this point is because if you look at preventing Alzheimer's disease, nobody exactly knows how can you prevent Alzheimer's disease, but some of the simple strategies to follow is good sleep, good appetite, exercise, active lifestyle. Most importantly, you have to reduce all the vascular risk and comorbidities risk, and exposure to toxins and trauma have to be cut down. If at all possible, improve leisure, social interaction, meaningful activities, and cognitive stimulation is an important component which we need to look at. Now, why am I emphasizing on this slide is because even though we might not be able to do a lot in the treatment aspect as of today, we can do a lot of aspects in terms of prevention. Now, when they've done studies on nuns and population where they have lived 80 plus, and there's a good book called Aging Gracefully, where you can read upon research on nuns' brains and how their lifestyles have been effective and helpful in preventing Alzheimer's. So it is important for us to look at that. If you see this slide, none of these things look very difficult to follow, but it seems to be a better idea to follow these things to prevent Alzheimer's, because currently the medications are not really effective in preventing it, or at the same time in terms of it causing further problems in terms of Alzheimer's disease. Just not about memory problems, a lot of other things which can happen, like behavioral issues and other aspects which can happen in relation to Alzheimer's. So I think I've highlighted to you about one condition in children, one condition in the geriatric population. So kind of we have touched at different areas of the brain, right? So before we wind up for the day, in the next 15-20 minutes, I'll try to kind of briefly highlight to an interesting area, which obviously a lot more research and a lot more work is going to happen in due course of time. What we are talking about is something related to obesity and those. And we know today, with all this COVID and other things happening, we know a lot of people have put on a lot of weight, and they are very vulnerable to further kind of become obese and those. So what is the neuroscience behind some of these aspects of medications? How do these medications work? I thought I'll brief it here, because a lot of times as postgraduates, we don't read some of these things because we're constantly reading schizophrenia, depression, and other conditions which are routinely being treated. So I thought I'll summarize it in very simple way for you to further read upon. So I have a question here. Which of the following substance is known to decrease appetite? Which of the following substance is known to decrease appetite? Is it leptin? Is it ghrelin? Is it neuropeptide Y? Is it the alpha melanocyte stimulating hormone? Alpha melanocyte stimulating hormone. Which of the following decreases the appetite? So these are areas which we hardly discuss. But if you really see, obesity is going to be a common problem as psychiatrists we see, right? Because a lot of the drugs we use unfortunately causes weight gain, and these are people who are going to, and because of the illnesses, sometimes they lead sedentary lives, they put on a lot of weight. So obesity is something we might not be able to run away from our clinical practice. So it's a good idea for us to understand what could be happening in terms of chemicals out there. So if you're talking about appetite, you'll understand the answer once you kind of talk about it here. So leptin and ghrelin, in simple terms, if you look at, when your stomach is empty, sometimes your stomach makes one sound, right? Grrr, grrr, grrr. That when your stomach is empty, that sound, grrr, so ghrelin. So ghrelin is released when your stomach is empty and increases the hunger. Okay, what does leptin do? Leptin is satiety. So if you've eaten enough and if you're kind of feeling full and satisfied, the leptin is the reason. When leptin works, your satiety center says, okay, enough. I'm happy about the amount of food I've eaten. Whereas ghrelin is grrr, grrr. The stomach growling is what ghrelin happens. When it is empty stomach, it leads to increased hunger. Now, what do you need to know about neuropeptide Y and alpha melanocyte stimulating hormone? I'll come to that here. Basically, you need to understand the most important structure we are talking about when you're talking about appetite is the hypothalamus. So in simple ways, there could be circuits which play a role in increasing appetite. There could be circuits which play a role in decreasing appetite. So there are circuits which play a role in increasing appetite. There are circuits which can play a role in decreasing appetite, right? So what is also important for us to know is there are these two important peptides, the ARP, agouti-related peptide, and the neuropeptide Y, which plays a role in increasing the appetite. It plays a role in increasing the appetite. Neuropeptide Y and the agouti-related peptide plays a role in increasing the appetite. So what are the ones which decreases the appetite, by the way? The one which decreases the appetite is the pro-opiomelanocortin neurons. The pro-opiomelanocortin neurons, what do? They release the alpha melanocyte stimulating hormone, and this alpha melanocyte stimulating hormone goes and sits in the melanocortin 4 receptors. By sitting in the melanocortin 4 receptors, it brings about decrease in appetite. So there are two important pathways. One increases the appetite, one decreases the appetite. The one which increases the appetite is the agouti-related peptide and the neuropeptide Y, whereas decreasing the appetite is linked with the pro-opiomelanocortin, POMC, pro-opiomelanocortin, which releases the alpha MSH, alpha melanocyte stimulating hormone, which kind of works on the melanocortin 4 receptors and thereby decreases the appetite. I think it's important for us to understand here that in the same pathway which we spoke, right? Let me highlight to you about different important molecules and how they function so that you kind of know the answer for this question also. Now, in the slide which I just previously mentioned, I told you about pathway which plays a role in increasing appetite and decreasing appetite. Now, phentermine, if you take phentermine, is a drug which is known to increase the dopamine levels and the norepinephrine levels. By increasing the dopamine levels and norepinephrine levels, it ultimately works on activating the opiomelanocortin receptors. Pro-opiomelanocortin neurons further go and stimulate the alpha MSH, the alpha melanocyte stimulating hormone, which works on the melanocortin 4 receptors, thereby decreasing the appetite. So, how does phentermine actually kind of play a role in weight reduction? It reduces the appetite. How does it reduce? By increasing the dopamine and norepinephrine, which ultimately plays a role on the pro-opiomelanocortin neurons and the alpha melanocyte stimulating hormone. Thereby, it leads to the decrease in appetite. That's how it works. When you're talking about topiramate, which is another drug which is very well known to be used in reducing appetite, right? Now, topiramate, if you look at, works this other side. What does it do? It kind of inhibits these Adhd related peptide release and neuropeptide release. How does it inhibit? It inhibits this by decreasing the excitation, that is, decreases glutamate release and it increases the GABA release. You know, GABA is inhibitory, so it increases the inhibition tone and it decreases the glutamate, which is excitatory. So thereby, topiramate plays a role in kind of reducing the appetite, and it works on this side by working on the Adhd related peptide and the neuropeptide Y release, and it works through the GABA and glutamate modulation. Now, it is important for us to know another antidepressant which is also used in weight reduction, bupropion. Now, bupropion is a drug again which is known to increase the levels of dopamine and norepinephrine. We have spoken about bupropion multiple times, so that's important for us to know. Now, there is a negative feedback loop which is linked with the melanocortin 4 receptors. The melanocortin 4 receptors, when it is stimulated, sends a negative feedback loop to the pro-opiomelanocortin neurons. This negative feedback loop is important because this is where another drug which is commonly used in weight loss plays a role, like naltrexone. We did speak about naltrexone even in the previous video series. So what is this naltrexone doing out there? The naltrexone kind of is a opioid antagonist, right? It's an opioid antagonist. So this feedback loop is inhibited and thereby further release of the alpha melanocortin stimulating hormone happens. So that is how naltrexone increases the effect of MSH, and thereby it decreases the appetite. So naltrexone stops the negative feedback loop, which works by stopping the opioid receptor through opioid antagonism. That's how naltrexone plays a role. There is this drug called lorcaserin, which is extremely important. Now, what does this lorcaserin do? Lorcaserin, something to do related with serotonin. So lorcaserin works on the 5-HT2C receptors. It is agonist of 5-HT2C receptors, and thereby it plays a role in reduction of appetite. Thereby it plays a role in reduction of appetite. These are some of the commonly used drugs which are used in reducing the appetite and obesity problems. Now, one of the other drugs which is very commonly used is called as orlistat. Now, orlistat is working at a peripheral level, not necessarily at the hypothalamic level. It reduces the fat absorption. It also known to increase the aversive reaction. It is known to increase the aversive reaction. Thereby, it can lead to diarrhea and flatulence, which can happen. Aversive reaction in the form of diarrhea and flatulence, which can happen. if you want to benefit out of these drugs, we know these drugs are individually not very, very effective. So sometimes combinations are used. Combinations like Topiramate and Phentermine is tried, Naltrexone and Zonisamide is tried, Naltrexone and Bupropion are tried. So there are different combinations which are these days tried more than just using individual drug in order to reduce obesity. Now, of course, with bariatric surgery and other strategies which are available, there are a lot of molecules which have been tried, but they have been removed because of its hepatotoxicity and other adverse reactions which it have caused. But as a psychiatrist, you also need to know an interesting clinical point here. Now, which of the following receptor activities explain weight gain commonly due to antidepressants or antipsychotics? You need to know common reason for weight gain among antidepressants and antipsychotics is what? It is basically because of two important things which happen, right? One is the H1 antagonism. H1 antagonism. Other one is the 5-HT2C antagonism. 5-HT2C antagonism, which is the reason why weight gain typically happens. Drugs like mirtazapine, quetiapine, clozapine, olanzapine, they're all drugs which are known to cause a lot of weight gain. So possible explanation is H1 antagonism and 5-HT2C antagonism. And they see that when both of these antagonisms happen together, they seem to have more weight gain potential than one of the receptors working by the molecule. So antagonism at both H1 level and 5-HT2C level seem to play a role in weight gain related issues. That's something which is important for us to kind of highlight and remember here. Now, I want to highlight something before we wind up for the day. It can be its own topic by itself. So I'll just briefly highlight here so that I kind of touch on the basics, not on the different molecules, which is important. What I want you to understand is a lot of times the patients whom we see, the women patients whom we see are going to go through pregnancy during the time of their illnesses, and when they come and consult over many years, they follow up, they might go through pregnancies and those things, right? And it is important for us as a clinician to look at few important challenges which happen with pregnancies. Now, one is you need to understand almost like 50% of them, especially with mental health problems, have pregnancies which are unplanned. Even though you might, from the day one, spoken to them about pregnancy and challenges and other things, you need to understand 50% of the people might have unplanned pregnancies. That's a challenge which you might have to deal with as a clinician. Another important point as a clinician, you need to understand when you're dealing with pregnancies is a lot of times early months would have happened. By the time they realize that they are pregnant, 6 weeks, 8 weeks, even 3 months would have passed by. So which basically means if at all there is a problem or a damage, the problem would have already happened. So you might not be able to correct it. So you need to understand the early months are very vulnerable and we might miss the bus because they come pretty late to us. And by the time they get confirmatory response that they are pregnant, time would have been lost. So that's a challenge for a clinician when you're dealing with pregnant people. Third thing is the moment they get to know that they are pregnant, they stop taking medication overnight. Now, abrupt stoppage is one more important challenge as a clinician we deal with. More importantly, people have unrealistic expectations also. They are taking medicine, but they'll say, Doc, are you 100% sure nothing will happen if I take this medicine and if I become pregnant? Now, it's very difficult for us to answer those kind of questions. Now, I'm not going to talk about which drug is safe, which drug is not safe. Here and there, we have spoken about it in topics on antidepressants and those separately. Here, I'm highlighting to you the challenges as a clinician we need to look at. So 4 core problems, which I think we need to understand as clinicians is unplanned pregnancies, early months could have already happened, so you might have missed the bus and you might not be able to help them much because early interventions might not work there. Abrupt stoppage, which is going to increase the chances of them actually having the psychiatric illness relapses, right? So especially if they're taking lithium, and if they abruptly stop lithium, we know for a fact that it can worsen the course of the illness. So these are challenges. An unrealistic expectation is something which people are going to have. So how do you challenge and deal with these pregnancies is what you need to look at. Now, if you want to help these people with pregnancy challenges and taking medications, as a clinician, it's good to prime them about taking decisions in an informed way. I think it's important for us to have conversations with them about how do they feel about taking medicine, not taking medicine, and some of the important data points on which we should talk to them is about family history of mental illness. Do they have a very strong family history of mental illness? Is there a strong genetic vulnerability they carry? Past history of illness and medications, which medications have worked with them, which medications have not worked with them, past history of episodes, hospitalization, suicidal behaviors. This all will give you an idea of how to talk to the current person who's sitting in front of us, or thinking of pregnancy, or who you think might become pregnant at some point of time when you're treating them, because they might be wanting to kind of expand their family, and those at that time they might actually, you need to prime them, and as a clinician it's our job to bring them into discussion table and talk to them about it. I remember when a lot of 18-year-olds and 20-year-olds who come in and meet us with bipolar disorder, with and they already have had very bad episodes when they leave medications, and if valproate is the only drug which is working with them, I'm already talking to them about planning, if at all at any point of time they think of marriages and pregnancies and expansion of family and all those things. It's a good idea to talk to them and prime them why it is important to plan the whole processes, because when you talk about all these things beforehand, the chances of you leading them into these challenges reduces. All these problems can be minimized. You cannot remove all of these things, but you can minimize. One of the important things you should remember as a clinician in pregnancy is bipolar disorder is one of the biggest culprits which can show its head during pregnancy, especially postpartum period. We know bipolar disorder is one of the commonest ones which can come in for the first time. And I'm sure a lot of you as clinicians know, almost there is 50% chance of recurrence in the second pregnancy. If the first pregnancy had mental health problems, and if it's a bipolar condition, it's almost 50% plus chance of they can have the second time pregnancy also having mental health issues. Why is it important for us to have clear cut data points on what's the diagnosis, what is the family history? Is because this is when you can talk to them about pros and cons of leaving medications, because a lot of times we see that they want us to help them in taking the decisions. uh, uh, yes, of course they want a very confident answer that nothing will happen, but if you can help them to take decisions, they're okay with it. Otherwise they kind of are guilt ridden if things go wrong. Now it is also important for us to look beyond teratogenicity. If we have to look beyond the teratogenicity and not just look at major malformations and problems when kids grow up. What should you look at? You can look for changes in pharmacokinetics. You can look for changes in lactation, prematurity, withdrawal symptoms, low birth weight, fetal growth, minor anomalies, behavioral toxicity. You can look for all of those things more than teratogenicity. And teratogenicity is going to be very, very high in the early development stage. That's why it's important for you to prime them, especially if they're on valproate and those, to kind of tell them that if they're going to take this medication and become pregnant, the chances of they having serious challenges with the fetus could be higher. So prime them and help them to understand how to kind of shift medications or how to plan for alternative medications. And also working with them is important because it's early development time. The first 8 to 10 weeks would remain very, very crucial. So as a clinician, I think it's a good idea for us to highlight these points and kind of remember how these things work. Now, um, last important point I want to highlight before we wind up for the day is, as clinicians, we are not gods, and we cannot do fortune telling and say what's the guarantee of these things, right? So typically, it's a good idea for us to put it across to them about a natural process. Like, for example, if you take 100 pregnancies, about 10 to 12 miscarriage, 10 to 20 miscarriages can happen at some point of time. About 2-3 major malformations can get reported in 100 pregnancies. 0.002% is chance of Epstein's anomaly. 0.1% is the chance of neural tube defects. 0.5% is the chance of stillbirths. 0.6% is the chance of congenital heart disease. So if you can tell the person who's sitting in front of us, especially the husband and wife, are sitting, and counsel them and tell them, see, normally, even without medications, don't think pregnancies are a straight line. Everybody's going to have normal pregnancies. There can be challenges. Unfortunately, with some medicines, these challenges widen up. In some medicines, most probably it might not, but it's a question mark kind of a thing. And some medicines are known to be very, very safe. So kind of trying to talk to them and making them understand realistic challenges which they deal with will help. So this slide is extremely important. I have used this in many of my patients to kind of counsel them and talk to them about taking realistic decisions about quitting the medications, because it looks very easy. Okay, you should not take any medicine, so quit the medicine. Now, what they don't realize is the illness can itself cause problems to the growing fetus. The illness can itself cause problems for the child who's growing up. So how do you handle those things? So talking to the family members as well as the patient about potential downfalls and risk factors, giving them realistic data, individualizing the data. These are all extremely important strategies for us to become the best clinicians out there and help the clients the best way. With this, I think I've highlighted to you about important aspects at various ages. I've spoken to you about pregnancy and some basic nitty-gritties of dealing with challenges of the scenarios. With this, we'll come to an end. I'll try to see if there are some questions and see if we can take up and answer a couple of them. So some of them, there's a question which has been asked about, sir, for ADHD and seizure line of management. Now, typically, ADHD and seizure can go hand in hand for various other reasons. Like one of the earlier drugs which was used as an anti-epileptic is phenobarbital, right? We all know phenobarbital used to make these kids become hyperactive and have a lot of ADHD symptoms. So many times we would change the phenobarbital to other anti-epileptic and their ADHD symptoms would come down. But the question is very valid, because some of these drugs, stimulants, are known to kind of decrease the threshold for seizure, thereby might have some seizurogenic potential which can happen. So the best thing to do is to kind of prime the patient's family about a potential risk of seizures, because they have past history of seizures. Slowly escalating the drug is the best way to handle these scenarios, and giving enough time to settle down at a particular dose is a very sensible way to address it. If need be, getting an EEG done, looking for EEG activities. If the EEG is already having abnormal activities, we know that they're more prone for seizures compared to somebody who has a baseline EEG which is normal. So if you're seriously thinking of having risk for seizures, you should always get an opinion with a neurologist, or at least get a baseline EEG done to see whether the EEG is normal even before you start the medications. And we also know a lot of psychotropics, once we start, right, EEGs can have its own changes. So it's a good idea for us to do it before. Is there any role for cerebropoietin or levocarnitin in Alzheimer's disease? Now, of course, there is a lot of mushrooming of micronutrients being sold and promoted and discussed. See, it is quite understandable that these micronutrients can play a role, but will it change the whole course of illness? It depends, right? Because the illness is happening because of multiple factors. So I think you might not be able to completely prevent it, but it is important for us to understand. If you look at people who have minimal cognitive deficits, or people who you are suspecting that these people might end up into dementia kind of a state over years, if especially they can afford to, because a lot of these cerebroproteins and other things are pretty costly and people might not be able to afford. So if you can give a try, it's worthwhile to think of these micronutrients. The problem with micronutrients would be is you cannot prove their efficacy overnight. In fact, there are a lot of interesting studies now about how lithium can be effective as a preventive strategy and those things. A lot of research happening on lithium being neuroprotective and those things. So we need to see there's conflicting data which comes up with these micronutrients and those. A lot of like vitamin E was promoted at one point of time. Estrogen was promoted at one point of time. Many of these things have no concrete evidences. Micronutrients you can give a try, especially if the patient is able to tolerate and can afford it, might make a little bit of difference for sure. Is diabetic brain more prone for Alzheimer's disease because of M-glutamate receptor in glutamate metabolism? To my knowledge, Alzheimer's disease in diabetes, right? They're speaking mainly because of is M-glutamate receptor is one of the things which can be considered, but they are mostly linking that with insulin and insulin receptors and insulin growth factors. Insulin receptors, insulin growth factors, there seems to be the pathology which leads to increase in Alzheimer's. How often you could have social interaction? Okay, I think social meaningful interaction is much better than anything else. Interesting point I would also like to highlight, because now, okay, I just saw the next question, behavioral advice for ADHD. So let me highlight a couple of interesting points for us to also know as clinicians and with evolving technology. The point here is, if you had listened to last lecture, we spoke about substances as addictive potential and those, but we also know behaviors have addictive potential. A lot of kids with ADHD, if you really see, the parents will come and say, sir, you are telling the child has ADHD, but if you give him a laptop or a mobile phone, he's able to play the same game for many hours together. Why do you think the kid is able to sit and play a game for many hours, whereas the kid is not able to sit in a math class for 20 minutes? The reason is very simple. The games have something called as an immersion factor. That games have an immersion factor where it kind of gets your attention to very high levels. And this immersive ability, which the games can give, a lot of real-time stimuli might not work. Let me give you an interesting point for you to look at. If you're an astute clinician, you might have watched your patients talking about it a lot more these days, especially with all this COVID and people being at home and working from home. Are you not seeing a rise in people actually watching Netflix and Amazon and YouTubes and various other things? When you listen to them and ask them questions, you'll realize that they're not enjoying these videos anymore. They're just binge watching. So these days, I routinely kind of ask many of my patients, do you binge watch, and do you kind of hours together spend time on digital media without any purpose and just kind of watch one after another? Now, you need to realize they're almost buzzing their head with a lot of information. If you actually sit and watch any of those series on Netflix or Amazon Prime, and even some of the YouTube channels which are there, they're very stimulating, very enriching. You learn a lot. In fact, it's very immersive. But the thing is, it's almost like cocaine being given to your brain and stimulated over a period of time. Can you imagine? I am constantly bombarding myself with all this information. And then next day I decide, okay, let me do my job now. My job is going to look very mundane for me. My job is going to look very boredom for me. Now, where is that cocaine-like stimulation from Netflix and Amazon and various other streaming videos? Whereas here, this job which looks mundane. So I'm going to neglect this and take it over. So if you see, there's a lot of behavioral addictive abilities which have increased. And one of the reasons is because of this immersive ability which these things have. And today the technology is so much more stimulating and kind of engulfing that it can keep almost all the areas of your brain kind of focused. So the danger of it is it's almost like taking cocaine. So I think it's important for us to realize these behavioral addictive problems could be quite a challenge for all of us to deal in the future to come. And it is no different from almost taking buzz of cocaine in our heads, is what you need to understand. The bigger problem is behavioral addiction will be noticed way much more later when the damages have significantly happened. Wherein cocaine at least maybe will cause physical health problems or financial problems. So people might end up catching up with us in 3 years to 4 years usage. But whereas in behavioral addiction, by the time they reach out to us, a lot of things might be lost. So an astute clinician would be working on these things and trying to realize this. And you also need to understand, if you go to the other side of the population, the elderly population, they are not very well versed with technology. So teaching them to use technology, teaching them maybe 20-30 minutes of gaming could be very useful, because for them cognitively it can stimulate and it can be a stimulatory behavior. So something which is bad for the young child could be used as a technology which could help the elderly people to stimulate, because they are not much exposed sometimes. So when they try to play a game, or when they try to kind of cognitively stimulate themselves by doing a screen time for about 20-30 minutes, it might be a very neurostimulatory kind of an activity. So using these kind of strategies practically could be very helpful. The best, simplest help is helpful strategy is social interaction, human interaction, meaningful relationships, love, care, bonding, and those. So these are some things which we should look at. I think we have covered most of the questions which are out there and done. So thank you very much for all of you being there. We will be having one last session of this Essence of Psychopharmacology next Friday, where we'll be talking about interesting drug interactions, and we'll be talking about aspects which would be very practically relevant in our day-to-day practice. Thank you. Have a great day and a safe weekend. Thank you very much.